Yeah. Okay, good. We're recording. Excellent. Good. Okay. So some of this you will know, but some of it is kind of a few more ideas and like tips and tricks, really, just to try to kind of encourage us to be doing fluid management well in children, because it's kind of a little more complicated than when you first start. So a lot of the time people think, oh yes, you know, someone is sick, we just open a bolus, we hang fluid, and that's kind of it. And you'll see, you know, sometimes in ER, that's how it can be going on. So what I want us to do is just to talk a little bit about how we can think about what we're treating with fluids, why we're treating it, and how we can actually be understanding you know, how we can know if a child is getting better or getting worse and what to do. So I want to start with, just by way of introduction, we have to be quite cautious with children. Knowing the weight is very important. That's a basic thing. Knowing why we're giving it, and then monitoring for any signs of under or overhydrating patients, very important. So first thing you want to do, and I love my ABC, and we all know our 3 signs of shock. And this is the most kind of, it's the first kind of foundation stone that we want to get in when we're looking at our fluid management. And the first thing really is to find out, is the child in shock? And then we're going to talk about the causes of shock, treatment of shock a little bit later. But those 3 signs, you have your fast and your weak pulse. Now be aware, if you have a child who has a very slow pulse, that's also possibly a sign of very, very late shock as well. So it's really important to be just aware of that. And then are the feet cold and clammy, and your capillary refill time, which hopefully you all know how to check. You press on the child's finger, you count to 5, and then you watch and you see the blood returning to the end of the finger. You count to 3. If it's more than 3 seconds, then that would be suggestive that the child is in shock. Now, in a child, you really need to have all 3 to confirm your diagnosis. But you can have like have a child with just a fast pulse, or maybe peripheries, but the CRT is okay. And that would tell you that the circulation is getting impaired. And a little bit of interference there on the lines. There we are, that's better, thank you. So if you've got a question, just either put it in the chat or just interrupt, and feel free to ask question. So fine. So what is shock? We covered our 3 signs of shock. Now the understanding we need to have is, why is shock a problem, really, rather than just what it is. And the reason it's a problem is we're not perfusing our organs. So the longer we leave a child just in shock, the more their organs are going to start to shut down. And then the shock just starts to get deeper. So what would be some manifestations of shock? Apart from those 3 signs, what else would tell you a child was in shock?
Hello?
Oh, hello. Yeah, Dr.
Yeah, you could have altered mental status.
Very good. Altered mental status. Can you tell me why?
Yes, it could be because of hypoperfusion to the brain.
Wonderful. Very true. That's the second one. Yeah, very good. Any other ones? Any other end organ issues?
Yeah, another thing could be they could have, because of hypovolemia, they could have poor urine output.
Very good. So we're going to talk about urine output a bit later, but that's very important. They're not perfusing their kidneys, so their kidneys stop making urine. And that can have big problems, because if your kidneys stop making urine, eventually you can get to a place where the kidneys will go into failure and will basically never make urine. So that's a problem. Any other organs that are affected? Okay, those are really probably the two most important ones, but the other one is the heart. So this is where you can get into a big problem, is as your shock is getting worse, the blood is not flowing to the heart. So that means that the blood vessels to the heart are not carrying oxygen to the heart. So then the heart doesn't contract as much as it needs to. So then the shock just keeps getting worse. But you're right, your brain, you start to have altered mental status, your kidneys stop producing urine. So I want you to imagine that you're on the ward and you're making your rounds, and you see that there's a possibility maybe the child came in, they were in shock, they've had some treatments. Can you tell me some other things that you would want to check to see if the child's fluid was doing okay?
Yeah, to check if the child is properly hydrated, the first thing you want to do is to insert a Foley catheter and see if the child is making urine.
Very helpful. Yeah. So any child who is in a coma or deep in shock, it's very helpful to try, if one is available, to insert a Foley catheter. Very good. It's the most important thing, actually. So yeah. So the thing I would say with urine output, just be aware that if you just ask the mom, child being, often they will not be too accurate. Sometimes they can be okay, but sometimes they're not. So that's why it's very important, urine output. Sometimes you can ask the nurses to be monitoring it. You can even count how many diapers are we changing. Other situations, you can just be putting a catheter, as you said. And then other things you're looking for, your other signs of dehydration. We'll come to talk on that later, but reduced skin turgor, lethargy, also sunken eyes, all these kind of things are very important. So it's very good if you have a child and you're concerned about circulation, you should always be asking about the urine output. One of the most helpful things. So once you've established shock, once you see a child in that condition, you need to really ask yourself 3 questions. And these 3 questions will determine what you're going to do next. So it will tell you, are we going to be doing, what is the cause of the shock and how are we going to do our treatment? So first question, are we looking at anemia? The second one, is the child malnourished? And the third one, is the child dehydrated? So we're trying to establish a cause for the shock, and then we are looking at ways to treat. So first thing really, I mean, you'll know the anemia guidelines. Some of you may have already seen it on Peds Ward on the various areas. You have kind of 2 thresholds, but just to say, very, very useful to know a hemoglobin and to know it as soon as possible. There used to be some HemoQ machines. I know the under 5 clinic has a HemoQ machine. It can give you a result instantly. There's sometimes one around in the ER, and occasionally you can find one in my office. It's very helpful to know the hemoglobin very quickly. It's like a point of care test. And just some things just to be aware of. A child with malaria, like a very high parasite count, you'll need to be sometimes checking the hemoglobin every day, because on day 1, they may come in, HB maybe 7.5, but you see a high parasite count, the child is really sick, lethargic. The next day it might be down to 6.2, then the next day 5.3. And so you need to really be checking, usually more than once. Another thing to say as well, we often have a bit of a challenge in ELWA, because sometimes when the HemoQ is not available, the hemoglobin from the lab sometimes is not always too accurate. So it's not always very easy. And I know that getting a CBC sometimes is can be quite a challenge. So the most important thing we need, I think when I come back, we're going to try to get a plan to get HemoQ machines back into circulation, because they're very, very helpful. So just to be aware, low hemoglobin, that may lead to cardiogenic shock, because you're not getting enough oxygen to the heart. So the shock that you've got will only continue to get worse. So you all know this sign here in the conjunctiva, most accurate way to look. And then if you're dealing with a palm that's very pale, that's where you are. So just to say, if you have a combination of shock, so you have fast pulse, delayed CRT, cold hands, and the HB is less than 6, that's when you need to be giving your blood. And just to give you your volumes, and I know sometimes it's not accurate, but if a child is not malnourished, you want to give 20 mils per kg over 3 to 4 hours. And the important thing is to give blood as soon as possible. So something that's very helpful, those of you who are on the ELWA, if you're working in ELWA and you're on the ELWA residents WhatsApp group, so I mean the people, you know, there's a WhatsApp group for all the residents who live on the ELWA compound. If you send a message to that WhatsApp group and you say, I have a child with HB, you know, I have a child who needs blood, very quickly you will find somebody, one of the people living on the compound will respond. So there is no need to be waiting for a family to be buying blood and all this blah, blah, blah. What you can do is you can say, okay, we're going to give blood to the child straight away, just take something from the fridge, and somebody from the compound will always replace that. They will always do that. So my message is don't delay. Just to say, if you have a child with malnutrition, the volume of blood is less. It's 10 mils per kg, because remember, these children get overloaded very easily. The other thing as well with malnutrition and transfusions, try to make sure it's happening within 24 hours of arrival or when they've moved to the transition phase, because if you do a transfusion on a malnourished child and it's happening when they're still recovering from everything else, if they get a reaction, you can have a big problem. So it's either straight away or in the transition phase. And the take-home message, I know it's not always easy to get blood quickly. So, you know, while the child is waiting, you give maintenance fluid. You don't just put up RL and start squeezing. You give maintenance fluid in a controlled way, because if you give too much fluid and the child is anemic, you'll find the shock will actually get worse. So it's very, very important to be giving blood at a nice kind of slow, steady rate there. Okay, other thing to say as well, if you don't have shock, the transfusion threshold is 5. Anyone less than or equal to 5, that's when you give blood. Really in ELWA, we're just using whole blood. I wouldn't worry about the whole packed red cells thing. So just be using the blood there. And again, it's 20 mils per kg in normal child and 10 mils per kg if they're malnourished. So those are your key things to remember. 6 is the threshold with shock, 5 if everybody else. But remember, say you have a child with hemoglobin 6.3, you wouldn't be running to transfuse, but you would be rechecking the next day. So you're following that child up. You're not just kind of leaving them. You have to follow that up. And again, remember I said we've got our 3 questions when you are looking at shock. I'm going back there. You have anemia, you have malnutrition, you have dehydration. And these are some causes. So anemia, we've covered. The treatment is to reverse the anemia, to get up, and then also treat the cause. Now, the reason we're asking about malnutrition is because anytime you give fluids, you need to know if the child is malnourished or not. If the child is malnourished, you're moving in a different way with fluids. I think we talked on that last week, so we'll not go too much into that, but you all know how to recognize a malnourished child. And dehydration. Very important to assess for dehydration, because the way you do your fluid resuscitation is different. It's much more aggressive. The reason it's more aggressive in dehydration than if you're just having septic shock or something else is that the cause of the shock is hypovolemic. There's not enough volume. Whereas if you have a septic shock, the cause is distributive. That's to do with your basically an endothelial cascade is the sort of the pathophysiology there, and that ends up with a lot of leaky blood vessels. But with dehydration, and the same with burns, if you have a shocked child with burns, the fluid resuscitation thing is similar. I'm going to leave the surgeons to talk on burns, but the important thing is dehydration gives it different. So your assessment, imagine everything's normal, you don't need to worry, you move on to disability. Remember I said everything is ABCD. So once you've got your ABCs, you move on to disability, and that's your coma, convulsions, all that kind of stuff. Then your next category would be if the child has impaired circulation, and shock would be if all three of the cold hands and feet, delayed CRT and weak pulse are there. Then you look at your cause of the circulatory problem, so anemia, dehydration. We're also going to talk briefly about anaphylaxis as a cause of shock as well. And your final question is, does the child have malnutrition? The reason for that is the treatment is very, very different if the child does have malnutrition. So, okay, can anyone tell me some causes of shock? What are some causes?
Hey, I'm Dr. John, I'm online. Do you want me to come in?
Yeah, feel free. Anyone can come in.
Okay, thank you so much. So for me, I think the cause of shocks, there are many. It depends with what kind of shock we have. So it can be a septic shock, which due maybe to a sepsis or any infection. It can be a hypovolemic shock, which is due to any loss of blood or any loss of blood. Maybe the child is bleeding. It can be sometimes due to any cardiogenic shock. So so I think for me, the cause of shocks, there are many in three different categories, which I mean infectious shock, which may be due to the sepsis, can be hypovolemic shock due to any loss of blood, or maybe it can be any cardiogenic shock due to any hypersensibility to any infectious agent.
Yeah, very good. That's kind of covered most of the areas there. So just to give you this little table, this kind of summarizes a lot of that. So really there's the four kind of broad categories there really. And just to say the first one, the kind of severe dehydration or severe bleeding, there's just not enough volume. So that gives you hypovolemic shock. So that's in that situation, you need to be very aggressive with your fluid. We're going to talk about the plan in a little while, but just to be aware, if you have hypovolemic shock and say you have a patient, they've been bleeding and maybe they also had diarrhea and you check their HB and it's 6.5, if you then put a lot of fluid in, you then need to recheck the hemoglobin because that fluid will have caused hemodilution and you may find, oh, it is now 4.5, oh dear. So that's your first category. Second one, I've written it very simply there, but it's to do with endothelial capillary damage through septic shock. Certain bacteria and viruses will do that. I mean, we all know about Ebola, but also dengue will do this. Malaria can do this as well. Various sort of Neisseria meningitis type things will do, and you end up with blood vessels where you get a lot of fluid going out through the capillaries, and it goes into the basically goes into a lot of the sort of soft tissue space. So that is, it's not so much hypovolemic, it just means that the fluid is in the wrong place. So you're still going to be giving fluid, but not quite in the same volume as hypovolemic. Then you have severe anemia. That essentially leads to a cardiogenic shock because the heart gets faster and faster. It can't keep up, and then it starts getting slower because it's not getting enough oxygen. And in that situation, the treatment is the transfusion. And then anaphylactic shock is the last one. Now, the treatment of anaphylactic shock is actually quite similar to septic shock, but you also want to treat the anaphylaxis. And I think in another talk, we're going to have that discussion. But really what you want to do in as well as fluid is you need to reverse that. So that's a situation where you're giving your 1 in 10,000 adrenaline, where you're also looking at a steroid, maybe an antihistamine as well, to try to reverse the cause. So those are your four kind of broad areas of what will cause shock in a child. There's one or two others that are very rare, neurogenic shock. I'm not going to go into that, but those are the four that you will see that are very, very common. These are the ones that will come into ELWA, especially really the top three. So just to recap, everything comes back to the A, B, C, D, D plus, whatever we want to call it. In shock, they're probably unconscious. It's very rare to have a child who's in shock who is sitting up and fully alert. So remember your airway management, the recovery position. Any child who's in shock needs oxygen, because even if their SATs are 99, they need help in getting the oxygen to the tissues. That's really important. And then remember your 3 signs, but also check for pallor, and beware that the pulse may start to get weaker and slower later on. I remember one child who came on PEDS ward, I think a year and a half ago. The child was also malnourished, and the pulse was all the way down at 60, and the heart was about to stop. So we had to put a bolus of fluid, and then the child was malnourished. So we actually managed to use Resomile and bring the child round. Just be aware as well, monitor blood sugar. If a child has reduced volume, they will sugar. If you're in a situation where you have no blood glucose machine, treat on suspicion. If you've treated your shock with your fluid, which we're going to talk on, you want to give some D10, and then monitor for diarrhea and dehydration. So just to say, the reason we think about the cause is because that determines our plan. So dehydration, you've got aggressive fluid management. Distributive, you've got boluses, which we're going to come and talk on. Same with anaphylaxis, and then cardiogenic is a situation where you need blood. So this is, everybody may have seen this. If you've worked in Harper or if you've worked in ELWA, hopefully you will have seen this. This is one of my favorite pictures. It tells you exactly how to manage, really how to manage a child. Yeah. So there we are. So you've got your 3 signs of shock. Then you ask 3 questions. Remember, is the child dehydrated? If they are, going another way. Yeah. Sorry, is there a question? Okay. Oh, hello. Hi. Sorry, I can hear some sounds. Is there a question? It's okay. You can ask a question. Okay, we'll come back to that. So you've got your 3 signs of shock. Then you're asking your questions. Is the child malnourished? Is the child anemic? And remember your HB of 6. If it's less than that, you're doing your blood. If it's greater than 6, you're thinking. For some reason I'm muted. Hang on. Hi, can everybody hear me? I'm having some technical issues.
Yes.
Yeah, you can still hear me. Good. Yeah, so I was having some technical issues that said it was muted. Okay, so yeah, so a child who is in shock and they are not malnourished, and let's say the HB is like 8 or 9, you're giving 10 mils per kg over 30 minutes of RL or NS. And you can repeat that again and again if you need. So it used to be 20 mils per kg. And years ago, before 2012, what you would do is you would just do 20 mils per kg boluses again and again, many, many times. And that's what I first was taught. But then there was a big research paper. You guys should all look it up. It's something called the FEAST trial. It was done in Malawi and also all the way down East Africa. Very, very important piece of research, the FEAST trial. It was award-winning research. And it discovered that actually in children with shock, we were giving too much fluid with our 20-20-20 boluses. So that's how we moved to 10 mils per kg, repeated one time, repeated another time. And if the child is still not getting better, then you move to maintenance fluids. So that's really the key thing. We've moved away from the 20 mils per kg repeat to 10 mils per kg every 30 minutes. So these children, you will have to be monitoring them very closely. You have to be going back to them all the time. So it's not like you're just kind of once or twice, you know, you can't just write something up away. And you have to keep coming back to them every 30 minutes to see how they're improving. Now, if they have shock and they're malnourished, you do 10 mils per kg, but you're using either DNS or DML, and you're doing it over 1 hour. So it's very, very slow fluids in a child who's malnourished. Anything after that, you need to try to use Resomal, either NG or orally. Is that making some good sense? We'll do some examples. So let's say a child comes and they weigh 15 kg and they have a hemoglobin of 8, and you see the child is not malnourished, but they are in shock. How much fluid would you give? Anyone can answer.
Yeah.
Yeah.
So I will give this child, because the child weight 15 kg and the HB is okay, there's no anemia, but we'll have, let's say, moderate anemia. I will start this child on, there is no malnutrition, right?
So no malnutrition.
So I will give 20 ml per kg.
Okay, why 20 and over how long?
Over 1 hour.
Okay.
So I will give the first 10 ml per kg in the first 30 minutes.
Okay.
And then I check for those signs of shock. If the signs still persist, I will go with another 10 ml per kg.
Very good. Okay, excellent, very good. So everyone hearing that, so 10 mils per kg, 30 minutes. Then if they're still in shock, you review again. And what if they're still in shock after your first 2?
So if they are still in shock after the 20 ml per kg, I will then want to reassess and see if there's no improvement. Then I will want to also go with another, to put on a maintenance fluid.
Okay, so you can do another 10 mil per kg. So you have 3 goes in total of your 10 mil per kg, and then you can do a maintenance fluid. So let's do another example. What if you have a child coming, hemoglobin is 4.3, you see the child is very malnourished, like really MUAC is like 9.2, and the child is really in deep shock and the hemoglobin is very low. What do you think we can do?
Hello?
Yep, go on.
Yeah, so because this child is severe malnourished and is in shock with with severe anemia, the first thing I want to do is to get blood to transfuse.
Okay, good.
So I want to get a whole blood to calculate at 10 ml per kg and
good.
transfuse over 4 hours.
Very good.
But
excellent.
Just while I'm waiting for the blood, I can start to give fluid, but very low.
Okay.
Very low at 5 ml per kg.
Okay.
But then,
yeah, go on.
I also want to make sure that for this child, because of the malnutrition, I want to correct or check for hypoglycemia. If this child is hypoglycemic, then I want to place them on a normal saline D5 or saline. And then the next thing is I reevaluate, check for other signs of shocks. If signs of shock persist, and then because fluid in this child is very key, I will not want to continue giving IV fluid.
Okay.
But whether I can go with Resomal.
Okay, sure. So some good stuff there. There's 1 or 2 things I'd do a little differently. So what you need to do, you're correct in that you need to give your 10 mils per kg of blood. Okay. If the shock is still persisting, or even while I was waiting, you can do your 10 mils per kg of DNS or DRL. That's fine. And now you're correct as well. You want to possibly treat for hypoglycemia. So the way to treat for the hypo would be D10%, just to be aware. So when you're treating your shock, you're using DNS or DRL. If you're treating hypoglycemia, you're using D10. Just to be aware of that. It's very important. So that's all very good. So the other thing is as well is you're right as well about your Resomal after that. So you have your one go at a bolus if they're malnourished, and then Resomal. So everyone getting that. Good. Okay. So just to say that again, so everyone's got it. Shock and not malnourished with a hemoglobin greater than 6. You're doing your 10 mils per kg bolus over 30 minutes. You can repeat ×2, so you have a total of 3. And remember, each bolus, you're coming back to reassess to see if things are improving. If they are malnourished, you're doing DNS or DRL, 10 mils per kg over 1 hour. And you don't need to repeat that bolus. Very important. And then just to say, after you've treated, your plan, if they are not malnourished, you're doing your maintenance feeds or maintenance fluids, or even feeds if you need to. And if they are malnourished, then you're doing your, you're basically starting NG Resomal. Almost certainly you'll need to do that with an NG tube. So remember, this is in a situation where there is not dehydration. So this is distributive or septic or anaphylactic shock. Now, everything is different if you have a child who has dehydration. We're going to talk about that in a second, but I want to introduce a new concept, maybe new to some of you, may not be new to all of you. So I want to talk briefly, and I'll need to do this this is more of a demonstration. So hopefully when we get you guys through the ETAP training, we'll be able to teach you guys and show you how to do this. Has anyone done IO access before? Anyone ever put in an IO cannula before? So has that ever been done? All right. Has anyone seen one going in? Okay, it's really, yeah. Sorry, go on, Dr. Coley.
Yes, I observed one, but I didn't do it really.
Okay.
I saw one in Harper.
Sure, in Harper, good, excellent. So the good thing is it's really not too scary. People get they see them in the child's foot and they get very scared, but it's really not too intimidating. It's a very easy, very quick way to get access and to give fluids. So you can use this in a situation where there's no way to find line. And you will meet a lot of children who are very sick, no way to find line. If they're in shock, to find the line is even more difficult. So just to show you the place, the most common, the best place is in your proximal tibia. And you can see this picture here, that shows exactly the position. So it's 2 finger breadths below the tibial plateau. That's exactly where you want to go. So you just sort of go in there. And you can see there, in an older child, you can use a humerus or a femur. I don't like to do that. It's quite difficult. So the easiest one is to use the tibia. And in terms of a technique, you can see what's going on there. You can either go straight in or you can angle it slightly. I find it easier just to go straight. You feel your tibial tuberosity when you're palpating with your fingers. You go 2 finger breadths distally, and you press on, you basically press on the top of the IO needle, and you press and you turn, and you keep doing that until you will feel, or sometimes you can even hear like a pop. And then you'll know that you're in. And you know you're in because when you take off the lid, you will see there'll be some backflow, some blood will start to come out. So I'll try to demonstrate the practical aspect more, because it's very hard to just describe it. But you have a needle in there, you push it in, you take off the lid, you pull out the needle, and you'll see some blood will be coming back. So just those are some that exist. You have some that can go on a drill. That's an even easier way. But the most common one we have here in ELWA is this blue one here. Just to say, there are some situations where you can't use them. If someone has a fracture on the same side, if there's an infection in the leg, very, very important. And once you've gone in one leg, you can't go there again, because if you go again, when you put your fluid in, the fluid will just come out through the site where you went in. And this is rare. The other things that are rare, you know, children with bleeding issues and osteogenesis imperfecta, those are very rare. I've only seen maybe 1 or 2 in Liberia with osteogenesis imperfecta. I wouldn't worry too much about that, but just be aware of where somebody has gone. And doesn't always work. Sometimes you can have problems. So for example, the needle might be a little bit bent, or sometimes it can become full with like bone marrow and it can get stuck. Sometimes the nurses can be very scared of these things. They've not seen them before, some of them, so they will be nervous and frightened to use them. So you just have to encourage them a little bit. And then you have what's called a through and through, which is, it's not good news. It's where the needle's gone all the way through the whole bone. And if that happens, you just have to take it out, try somewhere else. I'm not going to talk about mediastinal ones, but just remember to watch out for anything like any signs of redness or infection or pain in that area. That can sometimes happen, and it can cause quite a lot of problems when you see that. Any questions about IO access? I think it's one of those things I'll need to do a demonstration when I arrive next week. We'll do some demonstration on that. Any questions on those ones? Okay, yeah, that's okay. We'll come back to that. So I want to talk about dehydration. I know we've gone through a lot of things. We talked about shock, how to treat distributive shock, your boluses, your transfusion thresholds, but dehydration is something else I want to get clear in our minds, because especially when you're on call, you'll encounter these children in the night coming through the ER. More of them are coming now. And you know you have watery diarrhea. Most people will know this. You don't need to be putting a lot of antibiotics if someone has diarrhea, unless you're seeing blood or unless the child is more unwell and you're concerned about sepsis. Most of the treatment really is rehydration, and you have your different stages. But to identify that, you need to be watching and vigilant for those things. And I love this picture. It has everything there. So your sunken fontanelle, your eyes, your cheeks, skin turgors reduced, dry mouth and tongue, the abdomen's very sunken. All of those things will tell you that your child is being dehydrated. And you can see here the skin pinch in that picture there. The way to do skin pinch is you just hold the abdomen between your finger and your thumb. You count to like 3 or 4, you release it, and then you count how long it takes for the skin turgor to return to normal. And if it's more than 3 seconds, then you are dealing with severe dehydration. So those are your grades of dehydration. You have no dehydration, some, and severe. And the 4 signs we look at, remember, you don't need all of these signs, but there are 4 signs. You have lethargy, sunken eyes, slow skin pinch, and unable to drink. Now, the bottom one is the most important of all these signs, because if a child can still drink, they have a very good chance of improving and getting better. If a child cannot drink, then you need to really be helping them quite aggressively with your fluid management. So those are your 4 things: lethargy, sunken eyes, slow skin pinch, and a child who is unable to drink. And you really need 2 out of the 4, along with a history of watery diarrhea. So, okay, I'm going to take that away because I want to see who knows. Let's say you have a child who weighs, let's say 20 kg, and they are not malnourished, and they come to you with severe dehydration, and you see the child is not drinking, eyes are very sunken, and the mum tells you that diarrhea has been running for like the past 1 week, and they're very dehydrated. Can you tell me how much fluid and what fluid you'll give? Yeah, any ideas?
Yeah.
Yeah.
So for this child, the fluid of choice will be normal saline.
Okay, yeah.
And because of the shock. And I will give 20 ml per kg.
Okay, yeah. So you're correct in normal saline. So you would actually give 30 ml per kg. Can anyone tell me over how long? Yeah.
Yeah. So like you're trying to say this is actually this patient is actually very much complicated now. So you need to give you give like 30 mils per cake, like within if the child is malnourished, if the child is not malnourished, then you give it like within I think 90 minutes or so.
Okay.
Sorry, I just jumping in, but
That's
I
okay.
just one thing is around like an hour, half an hour or 2 hours like that. Then the other fluid will be divided. I just jumping in, so yeah, but it's something like 90 minutes to like that. 30 minutes per cake. I can remember 30 minutes per cake. The balance 70 mix will be all the following hours. Yeah.
Okay, so there's some good ideas there. So you're right, the 30 mils per kg and then the balance 70 later. Now it was a slightly trick question because you also need to know the age. So a child who is under 1 year, you're doing your 30 mils per kg over 1 hour. A child who is and then you do your 70 mils per kg over 5 hours. If they're over 1 year, you do 30 mils per kg in 30 minutes and 70 mils per kg in 2.5 hours. So that's how you're that's basically how you would do it if they are not malnourished. So you're correct in your 30-70. So you can see the difference here between how you would manage dehydration and how you manage just a distributive shock. So that one, the distributive shock is 10 mils per kg. Here you're looking at 30 and 70. So this is a lot more because the child has hypovolemic shock. Now, if they're malnourished, it's actually more straightforward because you are using Resomal. And I think we covered that a little bit last week. But remember, your 5 mils per kg every 30 minutes for 2 hours. Step 2 is your 5 to 10, but you do it every 1 hour. Remember, with malnourished children, you would use the Resomal if they have diarrhea. So even if they, it's very hard in malnourished children to tell if they are dehydrated or malnourished because the signs are very similar. But you would use the Resomal in that situation as long as you have diarrhea. Very good. And just to say again, I love doing a bit of repetition. You've got your 30 mils per kg. So your 20 kg child, if they're 2 years old, you would do 20 times 30. That would be 600 mils over your 30 minutes. And then for the second step, you do 20 times 70, be 1400 mils over 2.5 hours. So that's how you would do it. And then remember, you reassess after each step. So if you see things are improving, say, for example, you've been doing your fluid, you do your first 30 minutes, and then after 2 hours, you see a child is starting to wake up, they're starting to drink. You can also start to give them some ORS as well. So then when you finish your 70 mils per kg, they're having ORS. So just to say, malnourished children, very hard to make assessments of dehydration because the signs are very similar. So in that situation, you are using Resomal. That's the most important thing to use. And there's your plan. So 5 mils per kg over 30 minutes, 5 to 10 every 1 hour. Just to say though, if your child is malnourished and they cannot tolerate Resomal, so say they are really sick, they're very septic, they're just really bad, then you can use a little bit a very, very slow DNS or DRL, just 10 mils per kg over 1 hour, and maybe repeat that once or twice, but only if they cannot drink. The difference between severe and some dehydration, again, this is coming back to your sort of WHO stuff, really. Some dehydration, the big difference is that they are thirsty and they're trying to drink, and your skin pinch is slow, but not too slow. The big thing that moves you from some dehydration to severe is the inability to drink, because those children are not replacing the fluid that's going in, they're just going down. So just to say again, this is your some dehydration, very simple. You would admit you would use ORS, or if they are not nourished, and you use Resomal if they are. Very, very simple. 75 mils per kg again. And just to say, any level of dehydration and malnutrition, you don't, if they're malnourished, you don't need to say, are they severe or some? You just say they have dehydration and malnutrition, and you use 5 mils per kg. So a little summary, of fluids. Remember, for shock, you need all 3 signs, your 10 mils per kg bolus there. But if you have dehydration, even if you have dehydration and shock together, you're using your 30 mils per kg and then your 70, so 30, 70. And some dehydration, just ORS. And then if you have something called impaired circulation, that's when you have maybe 1 or 2 signs of shock. That's when you're using maintenance fluids. Maintenance fluids we're going to talk about in a second. I know everyone has slightly different ways of doing it, but maintenance fluids are probably one of the most important interventions in pediatrics in Liberia, really, because they stop children from getting sick. Very, very important. So just to say, your 3 signs of shock, you've got your 10 mils per kg RL or NS. Then you've got your IVs, 30 mils per kg if it's severe dehydration, and then some would be using ORS. And again, just to say, malnutrition is not too complicated on that side.
Hello.
Hey, Dr. Gono?
Yeah, you I don't know, is it because you talk about the previous slide, talk about 30, then I'm seeing here 10 to 20 for shock. So
okay.
I don't know, sure. It's kind of confusing.
Yes, it is. Yeah, so fluids are confusing. Thanks for the question.
Summary aspect, yeah, the summary error.
Thanks for the question. So I'm just going back to show you something. So when you have shock, but you do not have dehydration, so this can happen. You have shock, no dehydration.
Shock okay.
That's when you
shock due to all causes.
Beautiful. So like if they have sepsis or some other thing, that's when you use 10 mils per kg. But if they have dehydration, that is the thing causing the shock. It's dehydration. That is when you use your 30-70.
Well, yeah. So I want to know, a patient can be septic at the same time, or have a combination of both of them. Like, for example, if you have a patient who is maybe volume depleted due to maybe a bowel obstruction, but that bowel obstruction, if it's preparation, they can lead to sepsis, which can be contribution. So at that point in time, how can you say, oh, this patient shock is only due to sepsis, but it's not due to, because it could be a combination.
Yeah, that's a question. So that's why you have to, if you're
distributed aspect, also the
clarify
that one, because that is important for the volume of fluid giving within the short period of time you have.
Very good. So that's a very good question. So I just want to quickly come back a little bit to the start. That's why we have our, our 3 kind of questions that we ask ourselves right here. So these are the 3 questions we ask ourselves. When you've established shock, is there dehydration? So situation where you have, say, a bowel obstruction and a perforation, if you're dealing with a child who has, if they are dehydrated, so let's say they have bowel obstruction and perforation, you look at their eyes, they're very sunken, you see the skin turgor is reduced, you see the child not drinking, very lethargic, that situation would be dehydration. So in that situation, you would be using 30 mils per kg. But if you may have the same bowel obstruction or perforation or something like that, but they may not be dehydrated. They may just be in shock. And so if they are not, dehydrated, but they just have shock, then you would go back to your 10. So that's why when you assess for shock, you do your 3 signs, then you look at, is there dehydration? And usually you can tell if there is sunken eyes, or if there's lethargy, if the child's not drinking, or if the skin turgor is reduced. So you remember to have dehydration. So to get your 30/70, you need 2 out of the 4. So the 4 things are reduced skin turgor, sunken eyes, unable to drink, and lethargic. So you need at least 2 of those, plus diarrhea. I hope that one making sense. Yeah. So this is why I like this talk, because it can be confusing, because you have your 30 mils, your 10 mils, all these things. So that's why we have to, it can take a little time to get our heads around it. Any other good questions? That was a very good question. Okay, I want to talk a little on maintenance fluid, just more to say why we do it, who needs it, what's the purpose. So really, maintenance fluid, it's to prevent the child from going into shock or dehydration or something. Very important. Any child who is NPO, any child with severe respiratory distress, anyone with a bowel obstruction, and also any child who is unresponsive. So this is where we've seen some really good outcomes. Children who are, for example, severe malaria and they're in a coma, the thing that keeps them alive, yes, we're using antimalarials and we're using antibiotics and blah, blah, blah. But what we need to do, the thing that will keep them going, is actually maintenance fluid. That's very, very important. So our maintenance fluid, you don't want to just give straight NS or straight RL, but what you want to do is use DNS. So generally the way to make that, the nurses will make it for you, but you take 50 mils of NS out, you put D50 in at the top, and that will do it for you. Now, remember, if you have no dextrose available, you can use Ringer's lactate, but you have to make sure you're checking the blood glucose. Very important. You don't ever want to just be giving D5% as a maintenance fluid. Can anyone tell me why? Why is D5 a problem? Have a guess. That's okay. So D5%, if you're just using straight D5, the sodium levels are too low. So that's why you need to use something which is isotonic with your blood. So that's why NS or RL is much, much better. But you need some dextrose in there. So D5%, not a very useful fluid. We don't use it very often in children. DNS or DRL is your better one. Just to say, I know you guys, you have your, you have a slightly different way of doing maintenance fluids to what I do, but as long as you have a system, that's fine. And the way I do it is try to calculate the amount for 24 hours, but be aware you will need to divide that to try to ask the nurses to give so much each 3 hours. Because if you just say to the nurse, okay, my child is weighing 12 kg, give 1100 mils over 24 hours, you will find 1100 mils will go very quick. And then for the rest of the time, not too much will be going on. So that's why we have our 3 hourly. So the way I do it, say you have a child who is 8 kg. If they are less than 10 kg, you would be using 100 mils per kg. So you do 8 times 100, that would give you your 800 mils. And that is for 24 hours. Then let's say you have a child who weighs 15 kg. So your first 10 kg, that would be 1,000 ml. So 10 times 100 is 1,000. Your second your second part, you still have your balance 5 kg. That would be the 50. So 5 times 50, I'll give you 250. And then you add the two together. You have your 1,000, your 250. You add those up, it gives you 1,250. And again, that is your amount for 24 hours. I know some people are using the 421, that is also fine, as long as you have your system. Just to give you an example, the 12 kg child, your first 10 times 100 is 1,000, 2 times 50 is 100. So that means your total is 1,100 over 24 hours. 24 kg child, maybe someone can help me. How much fluid for a 24 kg child?
Yeah, so a 24 kg will be like
1,600.
Already there. Okay.
That's 1,600.
Can you tell me how you reach that?
So correct? the first 10 is going to be 100 times 10. That's 1,000.
Yep. Good.
No. The second.
Yeah.
The second is going to be 150 times 10 is 500. That's 1,005.
Yep.
And the 4 is going to be 4 times 25 to give 100. So that's 1,600 in total.
Perfect. Excellent. Very good. So that is how you get your amount over 24 hours. Now, remember, that is maintenance fluid. So that is not treating shock or dehydration or anything. That is just maintaining the child. But that is very important, because think about how many children come to ELWA who are in coma, who have had convulsions, so many malaria children coming through. So that's very, very important. Now, to do it in 3 hours, all you do is you divide by 8. So I usually tell the nurses, 1,624 hours, okay, divide by 8, then you got 200. Any questions on maintenance fluid?
Yeah, besides maintenance, I just want to say something practical like that. Yeah, instances where the patient will be, you'll be in hurry, like maybe the patient in shock or the patient on oxygen. You could not get to the machine that you need to do a weight. So there's formulas on the net that you can get around with. I don't know whether it's advisable to use those formulas against the month or against the year. Because there are instances where you have these and you have to estimate the weight, basically. For me, with my clinical experience, I could just, I'm most of the time right with when I see the chart, I tell you that this chart is XYZ and it's very close to that. Yeah. Very close to the estimated weight when I just see, because I have seen many. I think with you have seen many, so you could just estimate that this child would be around this kg, then give fluid or give treatment based on this. Then later on, you could be able to accurately get the weight. But like you said, it's important that you do the weight. But then in these instances where you are in an emergency, you cannot wean someone off oxygen because you want to do a weight. But that's the ABC is important as far as managing the patient. If the patient needs airway or breathing issues, you need to correct those ones before talking about other things. Even though the working hand, you cannot do one and maybe like compromise the other one. So I just wanted to comment as far as weight is concerned.
That's a really good comment. So what I will try to do is there are some formulas to calculate the weight. So I'm going to bring like maybe some poster or something that we can use to start to put up in the different areas so that we can have like weight estimations and things. Because you're correct in that, you've seen a lot of children. If over time we start to see lots of these, and then we do our estimates. But it'd be very helpful for everybody to have the formula sort of shown everywhere. So we'll get to that one. Very, very good point. Just to say very quickly, hypoglycemia. Really, I like to treat them less than 70 per deciliter, try to treat that. It's D10 5 mils per kg. Just be aware, hypoglycemia, treating a hypo is life-saving, but it's also a bit like, there's almost always a cause. So we have to be thinking about, well, what is the cause of that hypo? Is it malnutrition, malaria, some other kind of something going on? So we're going to cover more about tumors and meningitis, I think, in the next one. So we're going to have a little summary there, but any questions before I have to go?
Like you talk about hypo.
I just want to go back to this. Okay.
This one?
All right, go ahead.
Okay, my concern was just the 3-hourly fee.
Yep.
Yeah, in calculating the 3-hourly fees. Yeah, I just wanted a little bit explanation about this.
Okay. So let's say we have a 24 kg child there, 1600 mLs. You know that is the amount they will need for the whole 24 hours. And then you think about how many 3-hour periods we have. 4 hours. We have 8 of those. 8 times 3 is 20. So that's how we divide it by.
Okay.
Is that making sense?
Yes.
Yeah. Great. Excellent.
So you're talking about hypoglycemia. Yeah, with the sugar reading.
Yeah.
But I think you got some part of your slide. I don't know whether it's in this presentation. At some level, based on age, and also based on other comorbid illness, like maybe they got a 56 and up to 70. So there are ranges with age.
Sure.
There are ranges with age. Not across the board like 70, less than 70, but there are certain ages that you take from, I think 59 or so. 59,
very good.
I think. Not 56 or so. I think 56. I'm just forgetting, but I think this is even though we haven't gone through it in detail, but this is something that you need to bring out, prosperity with the age. It's not cut across.
Sure. So I'll try to talk on that one more later, but that's a very good point. There's 2 things really. There is different thresholds for neonates, but there is some controversy as to how low you need to treat. There are different guidelines depending on who you talk with, whether you do MSF, WHO, all those different groups. Some people will say, 65 is not serious. We don't need to worry about that. We only do anything when we're less than 56. So that's why there is a little bit of controversy, and you're correct really in the age thing as well. And also the other thing to be aware of, say you have a child, they're sitting up, they're drinking, glucose comes back at 64, but you see the child is there drinking some juice or something. In that situation, you can quite happily treat that orally. So you're correct in that it's not too much of a hard, too much of an exact thing. But yeah, we'll do another talk on the next one on
Thank you very much, Dr. Maggie. It's been a while. Ready. Hope to see you very soon.
Yep, I'm on the way.
Coming for the e-pack. Like that.
Yeah.
Thank you, Dr. Maggie. Goodbye.
Dr. Maggie. Hello.
Hello.
Dr. John, I have a small question here.
Yeah.
Which I think really is very complicated to differentiate the severe malnutrition type.
I've been messing out with you for a couple of weeks.
And the severe dehydration. It's so complicated to differentiate the two.
Very good.
And sometimes I feel like you can miss the severe malnutrition type maras, and you you give too much fluid because you think it's a severe dehydration.
Okay.
How can you help us to make that
very
clear,
good.
please?
Yeah. So the question is about trying to differentiate between malnutrition and dehydration. It is very difficult. So the first thing to say, when you're identifying your malnutrition, the quick way to do it is to use a MUAC, the mid-upper arm circumference tape. That's your very, very quick way to do it. Now, there is also the weight for height, but if you're in the ER, you're with the sick one, I would just get out a MUAC, do it very quick. There should be MUAC tapes around the ER at least. So that's the way to do that. But then if you have a situation where you have identified malnutrition and you also see the eyes are sunken and everything, the way we decide in a malnourished child if they're dehydrated is whether they have watery diarrhea. So if you have a child who is malnourished and they also have watery diarrhea, you would just put them straight on Resomal. You don't need to look at all the different signs of it. You just move straight to Resomal, because it's very, very hard to differentiate between the two. Because if you imagine, let's say you have a 2-year-old child, very wasted, eyes are sunken, skin turgor is poor, and there's lots of diarrhea, you can say, well, are the eyes sunken from malnutrition or dehydration? Really, it doesn't matter too much. You would want to put straight on the Resomal to treat the dehydration.
So what about the cardiac refill for in that case? Is it
very
important?
That is very important as well, because you need to check if the child is in shock. So if you have a malnourished child who is in shock, that's when you're doing your DNS or your DRL. That should be coming there. So any child needs their ABC. So even if they're malnourished, if you see shock and malnutrition and dehydration, you're seeing all three together, then you do your 10 mils per kg bolus of DNS. And then you're also putting Resomal on top of that as well. Very good point.
Thank you so much.
Good. So just to encourage you guys, I'm meeting a bit later with Dr. Okira to talk about trying to do like a full ETAT course for all of you guys, or at least some kind of ETAT course. As I know, Dr. Gono has been through it a bit as a trainer. Dr. King's been helping with it. One or two other people have been involved with it, but it'd be really good to bring you guys all through that. So I'm having a small meeting later with Dr. Okira to do that. Now, what I'm doing in these sessions is we're going a little bit even beyond ETAT, because you guys are you guys at the top of the tree, you're the doctors. So that's why we're going a little bit even deeper than the ETAT. But I really want to bring you guys through that as well. Be a really good experience. Thanks.
Yeah, sure. That's
Cool.
nice. Thank you.